there. All right, you guys, we'll start. The purpose of this thing was to talk about, not about enhanced surgical recovery in general, but really about three specific things that we're doing with it, and not really to lecture you, but to get some feedback on these two provincial documents. So, this, Brendan and I have been doing enhanced surgical recovery for so long that we have no idea now what people do or don't know about it. Seems like everybody must know everything about it because I've read 1,000 papers, and I assume any of our group has read enough about it to know, basically what it is. So it's obviously about this side of the paradigm. The remainder, all of the things, actually, I like this illusion because all of the things with enhanced recovery, or most of them are not, if you do this, all of a sudden you'll have much better results. Most likely, even the ones where individual studies have done statistical analyses, the anemia business, for example, I mean, it's dramatically different outcomes if you do a study just of anemia, but I think I doubt if in real life we would actually see such dramatically different outcomes, but every little nudge that we can do to make it better, I think, is what we have to do, and that's why I like the illusion here. It's not like you're expecting dramatic things, and if the surgeon comes to you, such as our surgeons have done, and says, well, I don't really think this particular aspect is important for my inguinal hernia patients because they're healthy, such as they say, for example, for the preoperative feeding and drinking. I think that's really pretty crappy logic. And, because you're nudging even those patients towards a better surgical outcomes. Now, this was the paradigm of our preoperative preparation is done on this, or because of this slide, let's say. This is from the UK thing. I really like the UK's information on it, but we all have traditionally thought that everything that we do is so vitally important. Maybe what happens on the ward is pretty important too, but of course the intraoperative is only one small box in this pathway, and the postoperative is one small box. In actual fact, the role of the stuff that comes with the patient before they actually come to the hospital is half of the work that needs to be done. And I know we recognize that to some extent, but we were hoping to do that a little bit more. All of this stuff needs to be discussed, and there's lots and lots of work to be done in the preoperative care of the patient, which we're incrementing, we're nudging away at. One of the tools that we thought would work to put together is this. As part of this preoperative pathway, and I should have, probably can't go back. In the UK, I think it's much more obvious to have shared decision-making, primary care, and all of these things up here. We think we don't have much contact with primary care in a tertiary quaternary care hospital. I'm sure it's much worse at VGH. They have half their patients come from outside of Vancouver Coastal, so you might see an easy argument that to involve the family doctor in their care is not possible. And I think that's a mind shift that is probably a mindset that we need to change. I'm sure it's not true, and I'm sure it's not true here, and we can involve people in that, the family doctors, and we've approached them about it, and the family doctors are actually very keen on being involved. And when you see people around here like Kathleen Ross, you know how keen she is. But even the regular doctors, we had a meeting with them, a Fraser Northwest CME thing, and there was very good support for this. Interestingly, and if we do a quiz, I'm sure you can guess the one thing which they said was a problem. No. How do we get paid for it? It's cynical. It's all about how you get paid for it. Yeah. There wasn't really an argument about the time, although that would be in the next step. But that's part of it, of course, because they think that some of these things will take too much time. And anyway, there you go. So it wasn't about patient care. It isn't about patient-centered care always. So Anyway, what I envisioned as part of this, particularly for colorectal, and probably the same applies to cardiac, and that is that some of these interventions need to happen, well, they all need to happen as early as possible. And I visualize that with a colon cancer patient, that's the ERAS focus, the first contact with the system wherein it's assessed that they're going to need or likely to need an operation has got to be when they have their colonoscopy. They all have a colonoscopy, they all get a biopsy, and that always is the thing which precedes any decision to have a surgery. And I visualize that 9 times out of 10, those GI guys know this patient's going to have an operation. Surely, when the surgeons do it, again, almost for sure. I guess there's the odd biopsy of a polyp that they expect to be benign, but it's not, so they come from an operation. But I thought to myself, well, if we can intervene with those patients when they are very first diagnosed or partially diagnosed by the gastroenterologist, that will give us a month, maybe 2 months in order time to make a difference. So I talked to Ken Atkinson and the guys, and I said, listen, if we set up a tool where you could start directing care right from the GI clinic, the colonoscopy clinic, will that work? And Ken said, sure, no problem, which I thought was pretty good. They do their EMR, I guess they use Plexi or one of those EMRs that you see wandering around the computers in the OR. They use it all the time. They use it there for making their reports. And I said, well, how best can we then communicate with the GPs? And he said, and I proposed this thing here, which is a letter. It's an Adobe PDF, which is a fillable form. And he said that they could fill it out right there and then. It asks for the family doctor's name, the fax number, the name of the patient, the personal health number, the date of birth, just enough identification that the family doctor will know what's being talked about, the patient's complaint, and then this, you won't be able, maybe you can read it, you probably can't. I've recently examined your patient, his name of enter above. I believe it's possible that he would be offered surgical intervention to address the pathology we have identified. As you know, patients who are optimally prepared, blah, blah, blah. So that's the intro, which the family doctors will hopefully know by the time it gets to them. And they're reportedly, according to them, they're going to fax it right from the GI clinic through their EMR. Fax, you say, why fax? Family doctors want faxes. They're not interested in emails and blah, blah, blah. So there we go. That's the hope of the initial intervention. The GI, the surgeons as well, Brenda's talked to them at their meetings, and they're reportedly relatively keen. We'll see if they're as efficient. They didn't like GI diagnostics clinic. They wanted to say surgery on it. So I added the subheading surgery, which apparently they're happy with. Very small words. I thought GI diagnostics clinic was pretty good. Yeah. We set up this program. We've been meeting with the Fraser Northwest Division. This is the thing which what do we have? We have Specialist Services Committee, the GP Services Committee. The way they've improved a family doctor care through the province is set up all these divisions, the divisions of family practice. And the Fraser Northwest Division is a very active division. It's Kathleen Ross is the president, blah, blah, blah. They've got a whole support staff like we're trying to set up with the medical staff. They've got administrators, and now they've got money. They've got a number of things, and they've set up some really useful tools. And so they're the obvious persons to go to partner with to make this work. And now this becomes another one of the BCMA acronyms of shared partnership. But we thought that there was 4 things that we could address with it. The first, the easiest target in some ways, is anemia, because it's pretty easy to diagnose anemia. And anemia is important. There was a big paper published in Lancet 2011. They reviewed 220,000 patients. 30% had anemia preoperatively. That's pretty silly, really, isn't it? The mortality is higher and the morbidity is higher for patients who come into the OR anemic, very statistically significantly, and that counts for all the confounders, So targeting anemia makes perfect sense, and you and I are all annoyed as all shit when somebody comes to the pre-admission clinic and they've been around in the system for 2 years and they come in anemic, and it shouldn't happen. So this needs to be traversed out to orthopedic surgery and so on and so forth. So this is again from the UK, of course. Where should we do it? Well, the best practice place to treat anemia is by the GP early. Even they say optimize prior to referral, and so a smart GP knows a patient is losing weight, has fit positive or frank blood in their stool, they know they're going to need something done, and they can address anemia right there and then. That's kind of a bit optimistic, but maybe when we get going with this pathway, that will happen. I think in the preoperative clinic in our setting, where we see them a week beforehand, it's obviously way too late, and obviously further too late in the when they're admitted. This was a pretty good article by Goodenough. I don't know who he is. Somebody in the States. Lots of articles published by Goodenough, and this was their pathway for evaluation of anemia, not just in colorectal patients. The family doctors said this was a bit too complicated. Thought it looked pretty good, but anyway. So we modified it a little bit, made it simpler. And basically, if the hemoglobin is less than 130 in a male, 120 in a female, measure the ferritin. If their ferritin is normal, then you don't do anything. Well, no, it's not that you don't do anything. You don't have to treat them with iron preoperatively, but you should rule out why they're anemic then. If the ferritin is between 30 and 100, it might mean that they're anemic, but it might not. But probably in our simple setting, we're going to do a trial of iron therapy and consider consulting a hematologist. I've talked to the hematologist. They're very keen to see people, money in their pocket, you know. If the ferritin's less than 30, then they clearly iron deficient. And if there's lots of time, you're like an orthopedic patient, you could just start them on oral iron, which is of moderate effectiveness. If it's less than a couple of months, then oral iron will not have time to be effective under most circumstances, and it's time to use intravenous iron. So I think the message with this thing is if you have somebody who comes in anemic, just don't sign them up for IV iron. There was a patient I saw the other day who had a mild anemia and was booked for IV iron. Well, IV iron is, the problem with our system is that there's problems with access to it, so it's worth finding out more. So we've actually encouraged the GPs when they order a hemoglobin to add a ferritin in. That should be what they do. And I talked to Aaron Garg about that, and he said, yeah, it's not that expensive a test. It's not worth worrying about. There's a whole bunch of other iron studies. That was where it's need more information, blah, blah, blah. And I said, well, should they order an iron studies panel? And he said, no, that's not worth it. But if you get a hemoglobin, get a ferritin. Now, an interesting question, whether we should do that in the pre-admission clinic. I think probably by then it's too late. It's, you've got to do it when it's time to consider iron replacement. So anyway, I think that's a pathway that's not too hard to work out. Now, the other thing was smoking, and as you know, we've got yeah, well, I'm not planning on us doing that. So, in truth, by the time we see them, it's too late. Yeah, the GPs, we've set up a standard order for them to send off to the medical daycare. It's done in medical daycare, and again, we've talked to medical daycare and about 50 people carrying clipboards around in white coats. People in white coats carrying clipboards around. And they have given us limited agreement that our patients will have accelerated access to the medical daycare for doing it. And it's, forget the dose. Somewhere, a dean actually wrote a thing on the board downstairs which says once a week for 3 weeks. But when I was talking to Maggie, she said, no, you can do it daily. There's one form of iron which you can actually give full iron replacement in one go, but the one that we're using, iron sucrose, you can't give it all in one day. So you can do it daily times 3. There doesn't seem to be iron sucrose rate of reaction is very rare. Yeah. Yeah. No. Yeah. That hasn't been a question here. So there's always 2 hematologists down there. So I guess if something happens, they do it. But no. So no is the answer to that question. Yeah. No seems to be the answer to that question, and I think it's still a good question. Yeah. That's it. Well, you know what? That's not part of my program. I mean, we definitely need to see the patients earlier. I don't think we should get them be part of this program. I think this should go back to the family doctors. And the reason is because of the rest of these things too. If we had a robust pre-admission clinic, we saw them at least a month, perhaps 2 months beforehand, and we had resources to do the other things, then we could talk about that. But, getting the family doctors involved is a really useful psychological tool. We need that in this hospital, and they're keen to do it. So I wouldn't personally take that as my goal. So, yeah. Yeah, that, and that's a good point. I haven't addressed that. Maybe that's our next step, but that wouldn't be our problem anyway, because the GI diagnostic guys are supposed to do it. The GI guys are referring the patients back to somewhere. They report to somebody. So, I mean, we could talk a little bit down the line if it turns out to be an issue. This is just preliminary. This is all things. So all of the ins and outs have not yet been evolved. Most patients come to the family doctor. Yeah. Yeah. This might subsume through that, sure. Although, yeah. I mean, yeah, yeah. I say I'm looking at a different paradigm because it's not just anemia. It's a whole bunch of things. So let me carry on with that, in fact. So the other thing is smoking cessation. Is smoking bad for you? Well, this is the study. This is the line here where you can't tell whether it's good or bad. So this study here traversed the line, but it's pretty obvious that smoking is bad for you. And as you know, so stopping smoking is good for you. The question is, when is adequate for stopping smoking? And this is from this paper. Basically, 4 to 6 weeks, immune and metabolic function normalized. So if you can get people to stop for 6 weeks pre-op, then you'll have a benefit. Even 2 weeks does provide some benefit, and in 72 hours, most of the carbon monoxide will be gone, but I don't think there's any evidence that makes any difference. So basically, we're looking at practical terms at that 4 to 6 week mark. 3 months would be perfect. I don't know about SSIs. Mostly the work is on pulmonary stuff, and this is from this paper that this is what they've looked at. Maybe I even have a paper. No, there is a paper that looks at that. I think actually they found at 2 weeks there was some benefit, and at 6 weeks there was statistical benefit. So there's a lot of resources for stopping smoking, and this is from stopsmokingforasafersurgery.ca, which is actually a website that was put together by a fellow called Oyston in Toronto. Sunnybrook he is at. And so there's a whole bunch of things. And the Ontario Anesthesia Association has taken on a big initiative to stop smoking. So in a way, one could piggyback on that if one was trying to just do the one-off. But as I say, I'm still talking about the program. So, and as you know, we're trying to recruit Susan Lee, and this is a paper that her sort of index paper published following a trial that she did in London, published in ANA September 2013, and she found that, I don't have my little cheat sheet, the incidence of, interestingly, the number of people who stopped smoking for the operation was relatively small, like 10%, but at 3 months post-op, patients who went through the intervention or didn't, about 10% of the didn't had stopped, and about 24% of the intervention patients had stopped up to 3 months post-op. That's pretty good by statistical standards. So I mean, that was one study, and there are other studies. The ASA, there's been a couple published in the Anesthesiology that shows it's a useful intervention to get people involved in stopping smoking. This is a very simple intervention. Basically, the family doctor says, you got to stop smoking, go to this website, and I'm going to give you a prescription for nicotine replacement. Susan was interested in doing things with comparing nicotine patches to the illegal inhalers. And I think she's found that the illegal inhalers actually are no more effective. So, but that's come. I thought they were illegal in BC. Oh, okay, there we go. We're just reading about it. Fair enough. Okay. The third thing is nutrition, and there's tons of evidence out there that patients who are malnourished, I think that's a relatively small proportion of our. I should have put this last of our surgical population, but there's tons of evidence if they're malnourished that they do more poorly. And there are tools, these little, very quite simple screening tools. NRS 2002, I think, basically asks, have you lost weight, your appetite down? There's only 4 questions, isn't there, or something very simple. And so we proposed that they should intervene with that. I mean, that's simple family doctor. Again, all of these things, Kendra said, this is not rocket science. This is all family doctor, meat and potatoes type of stuff. So, and they can, nutritional supplements. There is a suggestion that some of the pro-immune or whatever, nutritional arginine or something, nutritional supplements actually decrease infection rates and that. But there's dietitian. There's a number of resources, and so we're suggesting these patients under this. And then the last thing was the whole thing about physical fitness. And so this is actually where the term prehabilitation is being used, as far as I can tell. Franco Carli and Gabrielle have done a whole bunch on physical fitness, published a couple articles and editorials. We should get them to come out and talk to us. This is probably the one which I think the family doctors will have difficulty with, although, again, the physical fitness that you need to do is not very much. Go out walking. For thoracotomy patients, some simple static exercise stuff, decrease the rate of pulmonary complications. I don't know if I put that in here. No. Because I'm just racing through this stuff. They decrease the rate of pulmonary complications like 40% or something like that. So these can be quite dramatic. Now, if you get 40% improvement on anemia and 40% with physical fitness and 20% with nutrition and 20% with smoking, they'll come out, obviously, despite having cancer, much better than they started, which was my comment about nudging. So, that wasn't funny? Oh, I thought that was funny. So that's the proposal. Those 4 things, the family doctors said that Kendra suggested the average family doctor was unlikely to attack all 4 things at once, but they pick 1 or 2 of them that they thought they could deal with. And even that, I think, is pretty good. And if we find that the pilot hasn't even started yet, but it's taking a tremendously long time to do it, that it'll work. The family doctors are going to use a tool. Here, I thought I'd show you this. Alt-tab. Pathway. No. There. The family doctors have this website called Pathways. It's set up by our Fraser Northwest guys, and it has all sorts of resources on it. They have tons of resources. Unfortunately, as I'm using Internet Explorer 8, I can't show you any of them. Here's. But, for example, one of the obvious simple things here is that they've got, if you want to send your patient to an orthopedic surgeon, you can tick on this orthopedic surgery list here. It'll bring up a list of all the orthopedic surgeons in the area with their specialties and their waiting lists. Yeah. And so on and so forth. And the people who have privileges to access it, and I asked, why don't I? And they said, well, we don't need you. So now I do. But Dean should be on it. Maybe he is actually, pain management. They can go in and correct the information about themselves and that sort of stuff. So, and apparently it's quite up to date. So that's, yeah, across the province. A number of other divisions are using it. They've invested in it. They had money from the CME. And under this tab of resources, which is error on page. So under this tab of resources will be all of this stuff, what they're supposed to do, and then the various resources available to them. So it's not like you're just saying do it. We're providing them with backup support. So, okay, so that's this idea of, in essence, rehabilitation or something. Thing. That's our initiative, and we've got involvement from the family doctors. And full disclosure, I've been paid for going to meetings on this by you and your tax dollars. Anybody object? Brenda, of course, has not been paid for going to meetings on this because she's a salaried employee. Oh, well. All right. So now, I just wanted to talk briefly about these 2, well, how briefly, yeah. These 2 guidelines, guidance documents are called, which were put together. So the ERAS Collaborative was a group of about 30 people from all of the health regions and a smattering of nurses and surgeons. Ali Kamadi, who's a colorectal surgeon in St. Paul's, is the co-lead or something like that. Ron Collins, the anesthesia need from Kelowna, we've had him talk here. Some hospitals sent relatively senior administrators some regions, some hospitals sent no useful administrators at all. I guess you can probably imagine who that is. And Brandon and I were there, a number of meetings over, I think it's probably been 3 years now. And so this is the Enhanced Recovery Collaborative, which is now wound up. It's done its thing. These collaboratives were designed to get programs going. There are some funds left over that have been allocated, which are available for tidy up projects in essence. So John sent out a couple of emails about that, or somebody did, but it's basically, I think, been quite effective in getting in the whole program of enhanced surgical recovery for colorectal surgery going across the province, being supported. It's amazing that there are people who don't do it. Again, I've been involved with this so long, it seems like everybody must be doing it, but I guess there's some people, some places not, but most of them really have now got it. And of course, as you can imagine, it involves a huge amount of involvement of people and talking and paperwork and that. So we've been able to facilitate that by having common paperwork and pathways and that. So one of the things they decided that they should do is a couple of sort of guidance notes out of the collaborative, and this was one, goal-directed fluid therapy. So that it was chaired by Kelly Mason from VGH, and we had a couple. Do we have 2 meetings or 1 meeting? Maybe one all-day-long meeting talking about all the aspects of it, and there was about 20 people at that, and then a document was circulated. We did some adjusting and that sort of stuff. So, but basically, this is in essence, it's not a guidelines, it's not a standards, but it's a collaborative suggestion as to what we should be doing about intraoperative fluid therapy. So, what I did, everybody's now seen that, I guess, because Roland sent it out last week. It still is the latest form I've seen is still referred to as a draft, but I think it must be pretty late draft. The summary statements is that the collaborative recommends appropriate fluid therapy. So some of these things are pretty motherhood, as you can imagine. I don't know why it's underlined. Right. And so one of the main questions is how do you choose appropriate fluid therapy, and in whom do you choose it? And so basically the statement came out. Now the background is that when you're talking about a monitor, that there are some monitors available. You all know this. The simple ones like the pulse pressure variation that are built into the Datex machine are the simple ones. The more elaborate ones are the CardioQ that we've got, and then there's the Massimo has one that's built onto a pulse oximeter that they've used at VGH. Kelly said that they don't find that very helpful, very reliable. There's a flow tract from Edwards. Edwards has gone into a more sophisticated one called the EV1000, which I do believe we're going to get here eventually. The evidence for, again, I don't have to tell you this, all of the evidence for all these things is relatively weak and slowly getting a bit stronger as the technology gets a bit more sophisticated. The flow tract uses a pulse clamp thing. It's called I think a CNAP, if I'm not mistaken, on a finger to do things, and it's called a pulse clamp, which I don't propose to explain, but there was an editorial, I don't know if you saw, I think it was ANA or British Journal or something like that, saying, why are we using arterial lines when we have this technology available? That it's as good as an arterial line for measuring blood pressure. So I don't know if that's perfectly true, actually. Don't think it would replace it in open heart surgery because of vascular spasm and blah, blah, blah. But I certainly see in some cases where we're colon surgery or nephrectomies or something like that, where some people might put an art line in and others might not. Maybe those people who were thinking of putting an art line in maybe should be thinking of this type of technology, because that's a expert opinion, a judgment opinion anyway. So we didn't. I started saying all that because we didn't say what monitor to use, and because there's absolutely you know as well as I do, and we knew as well as at that meeting that the evidence for any particular monitor is not strong. Some of the monitors are used very effectively by some people. Some have trouble with any of them, and then there's the dynamics of the whole case. I think if one is going to optimize fluid volumes, what you need to do that is without a surgeon, because you can, as soon as you start getting into surgery, it changes the dynamics and catecholamines and blah blah blah. and it's much more challenging. But if one's going to use one, you're going to put the cardiac cue in. I think if you have an opportunity to do some of the optimization techniques at the beginning of the case before very much goes on, that might be the way to go. And then once the patient is optimized for their sort of baseline fluid, it makes sense that then you can manage fluids on the basis of fluid loss and that sort of stuff. And I know that's not a perfect philosophy, but anyway, the suggestion, these are just the suggestions in the collaborative, was that one should use a monitor for high-risk surgery. That makes some sense. That's the way we do things. However, the definition of high-risk surgery is open surgery, and I guess laparoscopic surgery is felt to be less high-risk surgery, which in our institution would not appear to be entirely the case, but anyway. If you expect long surgery, and there's some logic to that, because as you know, the longer the surgery, the more blood can leak away on you, and you don't know. So, they note that the 3 to 4 hour threshold is based on a variety of surgical techniques, not just in colorectal surgery. This whole collaborative is about colorectal. Or use a monitor on high-risk patients undergoing perhaps lower-risk surgery, such as patients in whom the ASA status was 3 or more. We have lots of 3s that aren't very high risk. So all of these things, I think rather than using these exact definitions, I might just use the thing. Use it on high-risk patients whom you consider high risk or high-risk surgery. Yeah. I don't know whether yes, I would think that would be considered higher risk surgery. So yeah. I don't think that was in the document though. I don't know if anybody corrects me. Yeah. First, yeah, but ERAS really isn't for emergency surgery, is true or not specifically, or wasn't. Yeah. Absolutely, yeah. I mean, the high-risk surgery, so the patient has been vomiting, and I mean, I consider one of the conundrums of this fluid management thing, particularly if you're trying to use restricted fluid, is if you bring the patient who's had a bowel prep, then you've got to start out by replacing fluid losses from bowel prep. Although mostly their bowel prep these days is being oral gentamicin and maybe a fleet enema, probably not huge fluid shifts, but nevertheless some. So, and you're right, the emergency surgery where the patient's been vomiting and that, you obviously have to start out by replacing fluid losses, estimated blood volume deficits. So the other, not said in here, of course, is to use the cardiac cue, use the hemocue liberally, and, because I think I've certainly been caught with low hemoglobins that I didn't expect, which means more blood loss than I'd assessed clinically. Now, they were very keen on, that's in general. This part here that was for using the monitors. This is just general comments about fluid management, and they were very keen on, they have an infusion pump on every OR at VGH, and every patient should have an infusion pump on their system for the baseline 2 mils per kilo per hour of fluid. I sort of spoke against that, but only really I just muttered because I can't stand these pumps because they alarm constantly and they're in the way and blah, blah, blah. But I guess at VGH, if you've got 8 AAs, you can cope with a infusion pump being in your way or something. I don't know. But that's something we should perhaps consider because, again, I'm really good at having fluid run away from me and getting more than I intended. I don't know if we have enough infusion pumps to have them in every we're talking about major ORs. We probably do, actually. If you want a pump, you can get one. That's the recommendation. Use a pump for your baseline fluid and then use free flooding for bolus adjustments. If there's evidence of hypovolemia and using either a monitor or clinical stuff, then give 3 mil per kilo boluses and reassess constantly. Colloid versus crystalloid was quickly skimmed over because the feeling is there's no evidence except in patients who have obvious contraindication. There's no evidence that colloids are bad for a patient who doesn't have risk of renal problems and blah, blah, blah. This is not an ICU paper, obviously, or a sepsis paper. This is an elective colorectal surgery paper. And so, as you know, the evidence comparing restricted fluid management and goal-directed fluid management. Now, goal-directed means you've got to use a monitor to direct a goal. This is restricted. There's virtually no evidence that there's any differences in outcome. So they suggested in the balance of a anesthetic, if you're not using a goal-directed approach, is that you should be using a restricted approach And the restriction is this. It's not too much. There was actually a blip in the NISQIP stats from St. Paul's where they had a blip of renal failures. And one of the questions was whether people are being so good at restricting fluid that they're tipping the patients into hypovolemia. And it's one of those good questions because you don't want to cause the complications of giving too little fluid. So they said the average total fluid goal, 4 to 8 mils per kilo per hour, and presuming that if we're trying to collect data on this, which we are in a loose fashion using NISQIP, and if you felt you had to give a bolus because they're hypovolemic because of the bowel prep, I think making a little comment in the comment field of the automated record would be a nice way of providing that information. Right. Yeah. I wouldn't argue that I see a lot of volume deficits on induction. I don't know, maybe other people. Of course, we all each do so few individual OR5 days that it's really hard to tell for sure. But anyway, the goal is zero boundless fluid therapy. I think that's all in that one. No. See, that's my end of the thing. Yeah. Oh. No, I don't have the other slides. Interesting. I think I've got I didn't. Yes. Actually, sorry, I didn't turn on the room. There you go.
That would be
They're
a
on
really good talk.
And the other thing about Ronell is,
Maybe
you can hear us now, or
in case they missed that.
Yeah.
you repeat the joke.
If you're talking about the orthopedic ward, then it might make sense actually if they transfuse iron before they come to the OR. You know, a lot of people languish with their broken hips or femurs or whatever there for a couple of days and then come to the OR. I know it's not going to make it higher in the OR, but it's going to help post-op.
Trying very hard not to dump on the orthopedic surgeon service.
Yeah. I'm not dumping, I'm just saying if we're trying to address the issue.
Sure.
Yeah.
I mean,
You can't find the analgesic?
I've got the analysis thing there, I can't see it now.
that's probably worth doing as a trial, actually. I mean,
Well, it'd be worth a discussion, because I really think there's a lot of lack of knowledge around when to transfuse, who to transfuse, additional things you may do before you transfuse. It'd be happening out there.
I don't think it's just orthopedic surgeons. I've been asked by surgeons. I've would verbally communicate to them, oh, I've just checked their hemoglobin while they're closing and it's 86. I'm very happy. And they're like, oh, can you just give a unit because it's going to drop another 10 points by the time they get to the ward. Just give a unit. And I'm like, well, no, I don't really want to give a unit.
That's an interesting conundrum. Yeah.
It happens all the time. It actually happens not infrequently.
like general surgery?
Yeah, I've had general surgery asked that too.
They have that much confidence in their hemostasis.
I guess.
I don't know, what is the right answer to that? I mean, because it's true, they will get transfused. If they're under 100, they'll probably get
They don't
transfused.
want to, they don't want to call it.
Oh, yeah.
If that language ends on days, if it trends down, it's predictable, right? Someone ends up giving a unit.
They do a restrictive, they had some sort of
I think
restrictive
there's
study they
plasma
did.
light on the ward.
Transfusion. They've had more than one study.
It doesn't seem to.
So what are you saying back there? Can you speak out
Okay.
to the group? Should we transfuse if the hemoglobin is less than 90 in the OR, recognizing that it will fall?
No.
No, agree with that? No. Okay, let's have a consistent
Well, unless
answer.
there's active blood loss. If
Well,
it's
sure,
drained
yeah.
or anything.
Or unsafe or whatever, yeah.
Yeah. I mean, but the hemoglobin always does drop, but then it always comes up a bit later on.
Yeah.
So maybe that's the lesson to learn, right? They are slower to mobilize. Anyway, I apologize for my slides. Obviously I didn't, all the work I'd done on the subsequent thing I didn't do. So the other guidance notes was this opioid sparing guideline. Basically the idea that opioids are bad, which again we all know.
They could kill you.
So again, I'm just going to skip through these and stop at appropriate points. I'm sorry, these will be classic awful slides. Epidural analgesia, the gold standard for open procedures. But there's little evidence in the literature for laparoscopic procedures being good. Theoretical benefit in high-risk patients, which, as you know, we've already talked about that, high-risk, most of our patients, high-risk surgeons anyway. A bunch of advantages to it. You should put it in at the appropriate level. Again, we all know that. We're not very good at putting it at the appropriate level, is my understanding. Yeah.
Both are right.
An actionable item on this is the potential for developing a regional program, again, within this group. I think a significant component of that regional position would be the preoperative placement of epidurals. There's an awful lot of wasted time that happens in the operating room during the slated case time that's devoted to putting in sometimes tricky epidurals. If you had the luxury of time ahead of time and give the initial bolus, financially it's very viable to do, and it would guarantee timely placement of epidurals in appropriate patients. And I think we need to really consider that, as we're looking to how we expand our role.
We've talked about that in between Rover, Heart 3, and POA. It seems reasonable that we should be able to consider getting epidurals in. So that would, I think that would fall back on the person in the room to look and say, listen, I'm going to be in this case, can you slip an epidural in for me? This
Or the day
guidance,
before. I think it has to be planned the day before. Get the person in early and be there, 7 o'clock so that the epidural's in by 7:30.
I think that's excessively optimistic. We can't get people in on time for anything.
It's not optimistic, it's realistic. It's done in lots of other places.
Yeah.
That in lots of other places.
We have to be able to change our paradigms if we want to make things work.
The suggestion is actually from this document to give is to ascertain that the epidural is working beforehand, which makes good sense. So, and is part of that type of paradigm. They talk about how bladder catheters are not affected in the literature by thoracic epidurals. And then the possibility of requiring other therapy adjuncts if the epidural doesn't cover all the areas. And so abdominal perineal resections would be the classic one for that. And then there's a little thing about monitoring, which actually is before the other things, systemic analgesics and adjuncts. So there was a vote against REMI, which in the meeting, I think that was just somebody decided, has this impression that REMI is bad and blah, blah, blah. So this comment is here. I'm not sure I fully agree with that. I don't know the data enough to know whether it's true. It doesn't really strike me as that true, but it might be wrong. Specific opioid use post-operatively, little evidence to support one being superior to the other. That's because I said that I didn't like hydromorphone. I think it's a dangerous drug, and but they didn't want to put in that strong statement. So, intravenous lidocaine infusions have been reported as being effective. Load of 1.5 to 2, 30 minutes before induction. I think that's likely to be poorly tolerated. I guess this is from literature studies. Maybe running it in over 30 minutes would be a thing. I would think a bolus of 2 per kilo, and most patients would make them uncomfortable. And then infusion of 2 milligrams per kilogram per hour. Post-operatively, minimum 4 hours, up to 24 hours.
And both St. Paul's and BGH have got their lidocaine protocols through.
Yes.
Calgary has just started theirs as well. So again, this is something we're going to work on and getting.
And by that, she means lidocaine being administered on the ward
On the
without
ward.
cardiac monitoring.
Yeah, for 24 hours.
And there is a model in the provincial formulary for that because of VGH, I think. So St. Paul's had it for a long time.
No. St. Paul's have just moved it out to the floor this month. Yeah.
St. Paul's is St. Paul's. Yeah. So we should hopefully be able to move that forward if the, I don't know where, maybe Wendy is the one that has to push that through as part of the P&T person. Well, you're not really the P&T person anymore, are you? Because we don't have a P&T.
We have to apply to pharmacy to have it changed in the manual.
Pharmacy is now Lower Mainland, so we should be able to apply just straight through from BGH having done it because it's all the same pharmacy.
Yeah. All right, good.
Then we have to get the nursing protocols put together, so
Yeah.
that's what I have to do.
Well, that, again, VGH must have nursing protocols. So.
No, I don't know if they do. St. Paul's, I've got all the St. Paul's stuff.
That would be a good thing to bully through because of this nonsense of having to come up with a separate nursing protocol for every hospital is a bit silly. NMDA receptors. Ketamine was, again, supported, and there's quite a long discussion, as you probably read, 0.1 to 0.4 milligram per kilogram per hour, which is calculated in per minutes, because I do it in per minutes on the machine, mics per kilo per minute. 0.7 to 6 mics per kilo per minute or something like that, and a half milligram per kilogram a bolus. All of this was discussed as being relatively as low dose, not associated with all of the bad complications. As you know, the study that we're proposing to do, we're just putting through ethics now for with the iControl NeuroSense machine, is the initial bolus was half per kilo, and the infusion was 10 mics per kilo per minute, which was a dose that's taken from the American Pain Society's document in Journal of Pain, I think. So, and again, supported as being of low risk for the associated complications, but effective for minimizing helping to reduce postoperative pain. I've tried that on some patients. I would be happy if other people would try it. So a half milligram per kilogram and a 10 mic per kilo per minute load. I found the patients quite drowsy afterwards. So I don't know whether that's just random chance or giving too much drug otherwise or what. So, I mean, if they're drowsy for this outpatient ACL study, then that probably won't fly. So if other people can give their experience, that would be very helpful. I'm not a ketamine user, as you know. I was brought up in the year where ketamine is bad.
Yeah, it's like on the high side.
There's no data on ketamine plus lidocaine, and it seems unlikely that they will be synergistic and get greater effects, the two together, than each individually.
Just
there'll be perhaps partly additive.
And just to mention that the recommendation is, if we're going to be running lidocaine up to the floors, that would be on no one with an epidural at all. It's only strictly non-epidural.
Oh, really?
Well,
Well, because of potential for confusion of
funny things will
bags,
Toxicity.
et cetera, toxic. So again, that's one of the things they put in their protocols. It's used with patients with non-epidurals. You know.
How about the idea of surgeons ask about local in the wound at the end of the case? If you're thinking of a lidocaine infusion, is there an agreement on that? About whether you,
Good question. Try not to use toxic.
I'd probably
doses
just make
of
it clean.
local. Probably putting some marcaine in the wound, which will be absorbed and removed, is not.
because it's always, I mean, I always hear the question, how much can I give? And you give the, and presumably you're then right at the threshold of toxicity if you're calculating it.
Good
So then,
question.
if you're running a lidocaine infusion,
I'll
that could
look
be
at that.
additive.
Yeah, that's a good question, so we should research that, because I don't know how much would be allowed, yeah.
Genetics.
It would be interesting to look at the laparoscopic bowel cases and even the TAPIS cases to see if you put them on lidocaine infusions, how much PCA they would use and how much less they might use. I mean, that would be a good population to study if
Yep.
you want to look at
Oh,
opioid
yeah.
reduction.
I'm sure, again, these studies that have looked at that population, that's the obvious population. I mean, it is unfortunate with the epidural, because in fact, you'll be looking at adjuncts in patients who have epidurals with inadequate pain relief. Got to give them something.
You could give them magnesium.
Yes, I didn't reference magnesium. They say that there are some studies that show that it's good. I thought I'd seen studies that showed it may not
That's what I thought too.
Yeah.
Saves money on muscle relaxers.
NSAID2 inhibitors, obvious. In fact, I'm perplexed by the writing here, because we basically agreed that NSAIDs and COX-2 inhibitors have, in essence, no, and I think Elena's come around to this, have no effect on anastomotic healing. If an anastomosis is going to fail, it fails with or without NSAIDs. So, there is unclear safety data. Recommend that you talk with the surgeon. I mean, if the surgeon doesn't want it, if the surgeon's rarity, then you're be unwise to give it. But fortunately, acetaminophen is obvious. They report statistically little evidence that in fact that its IV works better, but again, the guy in the States said it worked better. Gabapentin. So here's an interesting thing. Darius is putting all of his knee arthroplasty patients on gabapentin postoperatively.
300 milligrams.
300 milligrams.
Yeah, everybody calls one of the best lousy on the ward.
Everybody. They don't complain.
So now have a little chat about that.
So it's been interesting.
Why did you buy that?
You guys
I'm
just
still
thought
biased by the talk from that guy from the Therapeutics Initiative that said that gabapentin was hokey. So we need to have another talk by him, I guess. Clonidine, dexmedetomidine. Again, all of these things have individual papers that suggest they're helpful. But I think the feeling was at this collaborative that there just wasn't enough solid data to recommend regional anesthetic. Oh, and then the other thing, discharge planning, and this is actually this is obviously just on the side, discharge planning in these patients. A significant number of patients who are discharged on opioids from surgery postoperatively, like 60%, are still on it 3 months later. So in terms of a comprehensive pain management strategy, weaning from opioids is a vital component. So, but obviously we're not going to address that. So those are the two. There's actually another. There was another guidance on
Nutrition.
no.
Yeah.
Nope.
Nope. Telling you,
I'm not going to talk about it. So those are the two. My point of this discussion was not to tell you what to do, but rather to get together, and now we've run out of time to talk about it, but if anybody has any other firm feelings. Barry, no, you can't talk. Too late. Sorry.
I have no firm feelings.
I was just gonna say that the
He's gonna talk
discharge
to you.
planning part of it is probably just as important or
Yeah.
more important than the pre-op. Because a lot of surgeons wash their hands of patients, and I've got to do the surgery, I'm done. They don't know when to go and see their family doctor, or they can't get in, or they don't have one. Having just had my father go through AAA surgery, which is not ERAS by any means, but there's very little nursing home support because they're swamped and they don't get out to you. Like, the patients are left to flounder to some extent after a major surgery, is my experience. So I think there's a lot of work to be done in the discharge.
There is a lot of work to be done, and one of the things we've just done is a gap analysis across the surgical journey for all services, looking at this. And this is the proposal of this new surgical quality group. We're hiring someone actually to look at the gaps right across from the information the patient's given from the surgeon's office all the way to what you just said, going home with little information. So it's going to be a rapid change over the next year. We've hired someone actually to do that work. So it's well identified because it is a mess. It is vascular patients are getting information from 1994 in the pre-admission clinic right now.
And this is partly why I made this point that we really want to get the family doctors involved pre-operatively, because if they're involved pre-op, they will begin to know about post-op too. So it's if somebody disappears to a surgeon, 6 months later arrives back 3 months post-op, they don't know anything in between, that's a problem.
As part of this initiative, is there some sort of auditing process in place that's going to look at how much family doctors actually have altered the plans going in? Have they addressed any of these issues?
Yeah, because we've done this as a combined initiative for the preoperative optimization, there is, they want data on how well it's working. So yes, there will be follow-up of these particular aspects.
So in the pre-admission clinic, the nurses are going to ask, has your doctor spoke to you about nutrition, your hemoglobin, exercise, and smoking cessation? So we're going to track that and see how many physicians actually have done that. And they want that information back.
And the anemia has also been followed?
Yes.
An evaluation or something. Oh, did you pass the evaluations?
She sure did.
Yeah, sure.
Thanks.
No, I refuse to.
Thank you.
No.